I'm going to turn over to a video from Althea Shelton, who unfortunately was not able to be here in person today, but was kind enough to pre-record her video and will be here live on the screen for our Q&A. And she is a really talented researcher who comes, again, from a different angle that many of us have not encountered, is a neurologist who's interested in sleep, and especially interested in sleep with people who have developmental disorders. So I'm going to have her video take it away from here, and then we'll pick up with live in person from Dr. Stowe. Thank you.
Good morning. Thank you for inviting me to speak. My name is Althea Shelton. I am an associate professor at Vanderbilt University Medical Center. In our neuro sleep division, I primarily treat pediatric sleep disorders. And today I am going to discuss what can we learn from research on sleep disorders in children with autism and other developmental disorders. These are my disclosures. So let's start. Sleep disturbance is a common concern parents express to their children's pediatrician. Approximately 25% of school-aged children will present with sleep problems pertaining to sleep onset delay and nocturnal awakenings. However, the prevalence of sleep disturbance in children with neurodevelopmental disorders has been reported to be as high as 86%. In addition, patients with neurodevelopmental disorders tend to have sleep disturbances that are significantly higher than their age-matched, typically developing peers. And these sleep disorders or sleep disturbances commonly last into adolescence and adulthood. Displayed here is a chart from a review article that I wrote on neurodevelopmental disorders that commonly experience sleep disturbance and the type of sleep disturbances that they experience. We will discuss several of these, including autism, Prader-Willi syndrome, Smith-Magenis syndrome, and Williams syndrome. But before we do that, we really need to do a brief review of sleep neurobiology, because changes in sleep neurobiology play a role in sleep differences between typically developing children and those with neurodevelopmental disorders. So there is a two-process model of sleep regulation, and this posits that sleep is primarily regulated by two biological processes, one being the output signal from the circadian clock, which is independent of our sleep-wake history, and the second being homeostatic sleep pressure, which is driven by prior sleep-wake history. So the longer you've been awake, the higher your sleep drive or sleep pressure. Often, changes in daily sleep patterns are driven by changes either in the circadian clock or the homeostatic process. Circadian rhythms are genetically encoded by a molecular clock located in nearly every cell that generates internal timing of approximately 24 hours. The master clock is located in the suprachiasmatic nucleus of the hypothalamus. And so what you have when you have the synthesis of melatonin, the synthesis and release of melatonin is stimulated by darkness and inhibited by light. Light or dark entrainment proceed through your retinal hypothalamic tract to reach the suprachiasmatic nucleus where your circadian clock is located. And then that signal proceeds to your superior cervical ganglion, which sends a signal to your pineal gland where melatonin is made and released. Endogenous melatonin promotes sleep and stabilizes circadian rhythms through actions on the receptors of the suprachiasmatic nucleus. And it also inhibits ACTH responses in the human adrenal gland. So our master clock, our circadian clock, is encoded or driven by 4 proteins generated by 2 interlocking transcription translation feedback loops. There are 2 activator proteins that work together to promote sleep. And then during the early part of the night, they actually activate 2 repressor genes that produce the repressor proteins period and cryptochrome. And period and cryptochrome promote wakefulness and inhibit clock and BMAL. So with this understanding, let's move on to our first neurodevelopmental disorder. And we're going to discuss Smith-Magenis syndrome first, because this was the first biological model of sleep disturbance described in a neurodevelopmental disorder. Smith-Magenis syndrome is characterized by developmental delay, intellectual disability, behavioral abnormalities such as self-injurious behaviors, and sleep disturbances. Patient experience or exhibit sleep disturbances through their lifespan. There's often early sleep onset, frequent awakenings at night, and multiple sleep attacks during the day. Almost all of these patients have an inverted circadian rhythm. So in 2001, this biological model was described by a group of researchers that found that there was an inverted melatonin production in Smith-Magenis syndrome, regardless of age and sex. So what this figures show is the circadian variation of melatonin production. Melatonin levels are on the y-axis and time is on the x-axis. The solid lines represent patients with Smith-Magenis, and the dotted lines are controls. The age-matched control group included healthy children or adolescents hospitalized for small stature with normal results of cortisol, growth hormone, and melatonin production. The different panels are different age groups. So ages 5 to 6 are panels 1, 2, and 3. Ages 7 and 8 are panels 4, 5, and 6. Ages 12 are panel 7, and age 17 is panel 8. So what you see is that in patients with Smith-Magenis, melatonin production is higher during the day than at night. On average, the peak onset of melatonin secretion in Smith-Magenis patients was 6 a.m. With a peak time of 12 noon or 12 p.m. and melatonin offset was at 8 p.m. So there is an inverted circadian rhythm, an inverted release of melatonin. So they release melatonin during the day, and this causes them to be very sleepy and have multiple sleep attacks during the day. The excessive daytime sleepiness also leads to challenging behaviors at times. And then at night, they have multiple awakenings or sometimes don't sleep at all. So let's move on to our next neurodevelopmental disorder, which we're going to discuss, is Williams syndrome. And so Williams syndrome is a syndrome with multi-organ involvement and is often recognized due to a diagnosis of a congenital heart disease. Additional distinctive features include intellectual disability, over-friendliness, anxiety, ADHD, and endocrinopathies like hypothyroidism. There's also failure to thrive, hypotonia, and hyperflexibility. The prevalence of sleep disturbances in individuals with Williams syndrome has been reported to be as high as 65%. So what has been found in patients with Williams syndrome? So this shows a comparison of levels of melatonin and cortisol in Williamson children, children with Williamson syndrome compared to typically developing children. And so what you see is that there is a shallower drop in cortisol at bedtime in the patients with Williamson syndrome. Bedtime here would be blue. And so here's cortisol. Here are the patients with Williamson syndrome. Here are their cortisol levels. And here are the cortisol levels of the typically developing children. And then there's a less pronounced increase in melatonin at bedtime in patients with Williamson syndrome compared to their typically developing peers. And so it is thought that increased bedtime cortisol and less pronounced rise in melatonin levels before sleep may play a role in the occurrence of sleep disturbances, such as delayed sleep onset that's observed in children with Williams syndrome. Our next neurodevelopmental disorder that we're going to speak on is Prader-Willi syndrome. And Prader-Willi syndrome is a neurogenetic condition affecting many organ systems that occurs due to the absence of expression of a cluster of paternally expressed genes located at 15q. Prader-Willi syndrome is characterized by two phases in terms of clinical features. In infancy, there is failure to thrive, severe hypotonia, genital hypoplasia, respiratory problems, and feeding difficulties. Then, as early as 2 years of age, an altered phenotype becomes apparent with evidence of mild developmental delays, learning problems. At around school age, there is onset of severe overeating behavior resulting from an abnormal satiety response to food intake. Prader-Willi syndrome is one of the known genetic causes of morbid obesity. The prevalence of obstructive sleep apnea in this population has been reported to be as high as 80%. Other later phase phenotypic characteristics include growth hormone deficiency, short stature, and they often have a narcolepsy-like phenotype even when obstructive sleep apnea is treated. And so there are two genes that are part of the deletion region in PWS that are thought to play a role in their phenotypic expression. The first is the MAGEL2 gene, and this is most highly expressed in the suprachiasmatic nucleus of the hypothalamus. And if you remember from the beginning, this is where your circadian clock is located. Mice models that lack the MAGEL2 gene have been shown to have hypothalamic dysfunction, including circadian defects, in particular, decreases in period and cryptochrome. And if you remember, those two proteins promote wakefulness. And so if you have a decrease in these proteins, that's going to lead to excessive daytime sleepiness. In addition, there is a SNORD116 deletion, and SNORD116 mice models show that if a mice has a paternal deletion of a SNORD116 gene, they often present with REM sleep alterations, including EEG theta waves, abnormalities, and alterations of sleep characteristics. So mouse studies of SNORD116 mutations show dysregulation of the orexin hypocretin system. And so orexin is localized in the mid-lateral hypothalamus, and it gives rise to projections to all brain regions. Decreases in orexin or hypocretin, that's the other name for it, is the known cause of narcolepsy type 1. And what I always describe to the sleep fellows is that you can think of orexin as a factory manager and your other arousal neurotransmitters as factory workers. And so when orexin is not available, the factory workers don't always work or they don't work to the best of their ability. People with PWS have been found to have lower levels of orexin in the cerebrospinal fluid, but not as low as people with narcolepsy type 1. So let's finally end with autism. So estimates of the prevalence of insomnia in autism range from 50 to 80%. And disturbed sleep potentially exacerbates ASD-related symptoms such as impaired social interactions, presence of repetitive behaviors, mood disorders, and inattention or hyperactivity. VH et al. Studied patients with ASD and well-defined sleep onset insomnia and compared them to patients with ASD without insomnia. And what this study showed was that patients with autism and defined sleep onset insomnia, well-defined sleep onset insomnia, had higher variations in genes related to the melatonin synthesis pathway, in particular ASMT and CYP1A2. So dysregulation of biological pathways, maintaining proper levels of endogenous melatonin have been proposed to contribute to the expression of sleep disturbances in autism spectrum disorder. Sleep disturbances in autism spectrum disorder may be due to multiple factors, including abnormal receptor sites for melatonin, decreased melatonin production, and also increased breakdown of melatonin. So what can we conclude? The pathophysiology of sleep disturbances in neurodevelopmental disorders is multifactorial. When you look at neurodevelopmental disorders, changes / dysregulation in sleep neurobiology play a role in sleep differences between typically developing children and neurodevelopmental disorders. The clinical presentation of sleep disturbances is an amalgamation of all co-occurring conditions. Thus, varying interventions may be required to treat sleep and behavior problems in children with developmental disorders. Thank you for inviting me again to speak.